Welcome everybody to the MGH brain-PBM clinic rounds. I'm Paolo Cassano, and today is May 3rd, 2024. It's my great pleasure to introduce James Carroll, founder and CEO of THOR Photomedicine, who is going to present about PBM and the brain, why I do not believe any of you. James, thank you for being here, and please take it away.
Yes, I'm going to talk on my favorite topic. It's got a lot to do with parameters. I'm going to start with a disclaimer. So we have an FDA cleared product, so I have to say these things. So this presentation is intended to provide professional medical audiences like you with education on the background and state-of-the-art of photobiomodulation. FDA has not approved, cleared photobiomodulation as such in the United States. All references to photobiomodulation and its potential applications are for educational purposes only, at least for the Americans attending this presentation. In the United States, our
James,
products, just in case I mentioned.
Sorry to interrupt. Is there a way we can have you full screen?
I should be full screen for you. How would you? How do you do it? You've got to fix me as. You've got to pin me as the main.
Yeah, it's each person just pins him.
Mm-hmm. Yeah, we can do that.
You have to pin me. Yeah, do you know how to do that?
Yeah, yes, we did.
Yep, it's done.
Somebody may have to give instructions. I don't use a PC. I don't know how it's done. I use a Mac, but you have to usually right-click on my image, and then it goes full screen.
We did. I think
you get the option to make it go full screen, like pin this person. Otherwise, you're right. When other people speak, if you don't pin it, then you see the other person go full screen.
Okay, we're all set, I believe. I'm sorry for the interruption, just in case anyone didn't do it.
Right-clicked on that. Okay, I'm just doing my obligations to FDA. So in the United States, THOR products are permitted to claim temporary increase on local blood circulation, temporary relief of minor muscle joint aches, pains and stiffness, relaxation of muscles and muscle spasms, and minor pain and stiffness associated with arthritis. Any other condition mentioned in this presentation is not cleared or approved by FDA for THOR products in the United States. Use of THOR products for any other purpose would be off-label for people in other countries, like Anne, for example. For the UK, for Europe, United Arab Emirates, New Zealand, Australia, our indications for use are treatment of tendinopathies, chronic joint pain, back and neck pain, oral mucositis. Any other medical condition mentioned in this presentation is not approved for use in those territories. We've also got regulatory approval in Mauritius, for which you can treat any disease you like with photobiomodulation. So we should all move to Mauritius, which would be nice. That's disclaimer. Disclosure, I am founder CEO of THOR Photomedicine, Inc. and THOR Photomedicine Limited and THOR Photomedicine in Europe as well. And I'm a co-founder and I am an investor in another photobiomodulation company called Lumithera. So all of that means that I'm extremely biased and you can't believe anything I'm about to tell you. I started my life as an engineer designing radio stations. I'm not a scientist, I am not a doctor, but I have been doing this for a long time, since 1987. So this is my 36th year in this field. I've co-authored 35 academic papers, 8 of them with Harvard-affiliated hospitals and schools and whatever around Boston. I've co-authored 4 academic books with people that are around there. My expertise or my reputation is on dose and beam parameters, so I'm going to mention quite a bit of that today. I've been an expert reviewer for the journals that publish most of the work in this field. I'm a past chair of the Biomedical Optics Society Conference on Photobiomodulation Mechanisms for the last 10 years, and I've joined a couple of other interesting clubs. Oh, yes. I thought I'd disclose something else today. I left school at 16 years old. I have no qualifications whatsoever, just lots of experience. And our collaborators and funding are listed here. We've been collaborated with 60 different academic institutions around the world, trying to find out how this thing works, what the dose of, what the dose response is, dose rate effects, what the clinical benefits are, the economic benefits, even the environmental benefits of photobiomodulation. From my point of view, and for those of you who really are only focused on the brain, have not really looked outside of the brain for the sake of PBM. There's a lot of evidence for use outside the brain. So musculoskeletal pain is where the strong evidence is. Hundreds of randomized controlled clinical trials in that field. Treatment of oral mucositis, there's 58 randomized controlled clinical trials on the effect. This is a side effect of high-dose chemotherapy and radiotherapy. People using it to improve their athletic performance, so using it before exercise to improve their strength, endurance, and their recovery. Dry age-related macular degeneration, the leading cause of blindness in America and the rest of the developed world. You have 15 million people in America right now with a diagnosis of age-related macular degeneration, the dry form, which is untreatable, and they're all going to be blind within 10 years. Nothing you can do about it, but Lumathera, which I'm an investor in and a co-founder of, have demonstrated in 8 clinical trials in Europe and 10 clinical trials in the United States that it improves visual acuity. So this is where the strong evidence is. Here, moderate levels of evidence, people using it for treating lymphedema, wound healing, neuropathic pain, fibromyalgia, and other things. In the brain, most of us have been here before and we've all spoken to each other. So a wide range. This is not comprehensive. You've probably spotted something that I have missed, and you're welcome to message me and say, add this to it. It's not perfect. I've added acute MI, acute myocardial infarction. That's remarkable. That is just by sticking laser beams into the tibia of patients, causing a mobilization of stem cells, and they start circulating around in the bloodstream. And of course, they find their way to a heart attack in a heart attack model in a rat, now in humans, and they find their way to the heart, and you see less scar tissue as a result. So you get this reduced infarct size as a consequence, and it works. So I thought I'd mention that. They've also, by the way, done it for the brain. They have done it on an animal model of Alzheimer's disease as well, to some good effect. Just putting light in the tibia. And just in case you didn't know, just to bring you up to speed, in case you live in a cave, just thinking about the brain, outside the cave, people using photobiomodulation, there's 1,432 randomized controlled clinical trials on photobiomodulation, 485 specifically in dental or oral applications, thousands of laboratory studies, and for a total of, as of yesterday, 10,195 academic papers in total on this subject. So it's quite well documented now. And for our own products, we've calculated they've delivered 36 million treatments, and yet most doctors have never heard of it. How weird is that? Anyway. So my plan, I'm going to set the scene shortly, and then I'll get to why I don't believe any of you. You are welcome to take photographs or screenshots, and you can stick them on social media if you like. You can hashtag it Thor Laser if you want, but only do it if it makes me look cool. I'm going to contradict myself. It seems likely I'm going to contradict myself. Photobiomodulation research is full of contradictions, and so it seems likely that's going to happen. Anyway, so setting the scene, I just want to remind you all, I say remind you, if you didn't start off and haven't sort of grown up inside the world of photobiomodulation, you will have, but you're hearing about it now. You keep hearing a lot about parameters, and this is going to be the main focus of my presentation. And I'm not expecting you to become experts on this by the time I'm finished. I'm not even trying to teach you, but I want to teach you where, I'm not going to teach you to understand all of this. I just want to have a bit of an appreciation of it, and where I think some of the problems are, and why I don't believe, not just you, it's not personal, I don't believe anybody, and because we own a company and we have spent, £100,000 on light meters of various kind, power meters, meters that measure wavelength, devices that should measure irradiance, devices that measure beam profile. And now I mentioned all of those, I think of the devices we've got, and I'm going to call that £200,000 worth of equipment around our place, trying to get these things right. And at the end of it, I'm going to tell you, I don't trust you. I don't trust me either. And we've got some of the finest instruments you can get in the industry. And there's so many ways to kind of work on this topic that when people talk to me about dose, I actually end up, I mean, I don't believe you when you tell me, because I know how easy it is to make mistakes, and we can't even agree amongst ourselves in my building here, so in my factory. Power. So people talk about power. It's the number of we kind of have some sense of what power is. It's the number of photons per second that come out of a device, even if it's a light bulb. This group here, Ethne Nussbaum from Canada, so they did a study where they went around checking lasers and LED devices that are being used in and around the Toronto area, taking a power meter to see how well they performed compared with the devices that were available on the market. I'm kind of wishing that Juanita Anders was on here, and I keep looking for her thing, but I don't see her or anything on here, because I know she'd be nodding. I mean, many of you are already nodding. Devices are not delivering what they say they're going to deliver. And so how many devices delivered 100% of what the manufacturer claimed? And the answer is not many. Some of them were close. Many of them were delivering zero. Most of them were somewhere in between. And their results are, well, their conclusion is that laser systems were delivering, the mean outputs were about 60% of what manufacturers claimed. LED systems were delivering about 31% of what manufacturer claimed. And now these days, if you're on Amazon, if you're anywhere on the internet, if you've ever put the word photobiomodulation into Google, you're probably now getting advertising for these devices. And they're not performing as they say they should. So Paolo mentioned our whole body THOR, which I quickly stuck a slide in there. And just for our own device, we know what people go around claiming. There's a company called Lightstim that make a light bed as well. They're claiming 60 milliwatts per centimeter per squared. We tested it, it delivers 13. And there's another one called Theralite, claims they deliver 100 milliwatts per centimeter squared. It delivers 8.75. Unfortunately, this is just the way things are. And patients who are buying these things off Amazon and like, well, it's I don't know if they're going to get anywhere close to what they think they're getting. And again, if Juanita was here, she'd be telling you how she's been involved with testing devices recently, and she's had the same issue. Paolo, I think you sent me this. It's a long time ago. You said, I think it was you who sent it to me, and I'm talking about certainly more than 5 and maybe as long as 10 years ago, and just said, we can't make sense of this and it doesn't seem to add up. Would I have a look and figure it out? 70 milliwatts per centimeter squared, delivered for 30 seconds per point, was reported as 10 joules per centimeter squared. Do the calculations, it's 2.1 joules per centimeter squared. Not even the academicians, the scientists, the doctors writing papers get things right. This isn't isolated. This is common. I'd expect to find this in more than 5% of papers, possibly as much as 10% of papers. Just, I say it's elementary. I know people get confused with parameters, but you find it's wrong. There are simple mathematical errors in the papers, and the reviewers are just not catching it. So I know you all want to, if you kind of have an urge to get involved in PBM, maybe you already are, you read the literature and you try and make sense of it and try and get some guidance from it. I'm here to tell you to have your radar turned on for, to be skeptical about just everything you read about photobiomodulation parameters. I was involved in a paper called The Dark Art of Light Measurement, Accurate Radiometry for Low-Level Light Therapy. It's had so many names, this field. Hopefully we're going to stick to photobiomodulation. If you're out on the internet, you'll see now that people are calling it red light therapy all over the place, but all the academic papers are calling it photobiomodulation. So we systematically reviewed all the data from March 2014 for a year. 74 articles met our inclusion criteria. 96% of articles reported a positive effect. None of the papers reported a negative effect. And there was a failure to meet parameters. 41% of papers didn't report the power, 41% didn't report the beam area, 43% didn't report the irradiance. If you don't know what irradiance is, it's sometimes called power density. It's the intensity or the brightness of the light, if you're not technical. So the intensity of the light is irradiance. The time it was treated, people were treating it, 16% of people didn't report how long they applied the light for. The energy, you often hear it reported in joules, so 74% didn't report that, 16% didn't report what more commonly is called the dose. Some people call the energy the dose in joules. It doesn't, that doesn't help you, does it? There's people reporting the dose as joules. There's other people reporting it as joules per centimeter squared, called fluence. Now, if you're not immersed in this field for years, you were probably dizzy 5 minutes ago, and I only had to go through 3 lines, and I began to lose you. And I'm sorry for this, but this is the reality. All of these things are necessary in order to do repeatable experiments. So fluence is the joules per centimeter squared. You see, 73% did not report any light measurement method. And we know that manufacturers are not making what they say they make. And whilst we have lots of parameters that disagree with each other, they are at least in the same kind of zone kind of thing, but and they're supposed to be calibrated. And I know, I'm not going to look at anybody in particular, but I've been in some labs and I've seen a power meter there, and I've looked, and you turn it over and have a look. Just see, when was the last calibration date? It was like 5 years ago. You know, it has to be done every year. Anyway, only 5% of academic papers reported a full set of parameters. So that was me, kind of helped me get through this lot. So where did we get to? Beam area. So yes, the area is quite simple, isn't it? It's the size of the beam that arrives on the patient. How hard can that be? You'll be surprised how hard it can be. Start with a single beam here. People often think and believe that it is the size of the hole in the tip of, in this particular case, a laser beam. If you were a dentist, you might imagine it was the size of the aperture there. And you might imagine it looks like that. It looks like this here because I've used Photoshop on it to actually expand the beam to cover the whole area. The reality is it's showing white there, by the way, on the tip. What we've done, we've taken a piece of paper towel over the tip of here so the light stops at the end of it, and you can see a pattern on the paper towel. It's white, even though it's a red beam, it's white because it's so bright that it is saturating the CCD, the camera sensor in my iPhone at the time. So it was too bright for the camera to measure it. But that's where most of the intensity of the light is. It comes down the middle. Everybody thinks that you take the power and divide it by the whole area. You have to take the power and divide it by the area where most of the light is. What do you mean most of the light? Can you be more specific? Yes, it's called the 1/E squared point. Oh no, more technical terms. Yes, it's about 86.5% of the area of the beam. How do you figure that out? You need a beam profiler to do that kind of thing, and it will tell you with the intensity of various gradients here across a light guide like this kind of thing. And there is a way of determining where most of the light is, because whilst most of the light here is in the middle of this single mode laser here, most of it's there. Gradually, as you move further away from it, the beam gets weaker and weaker and weaker, and you will see here that you can hardly see any little bits of light. How, if you're going to divide the whole power by the whole area, where is the whole area? Well, you don't want to, because there's almost no light out of here, and you really, but every time you expand the area to meet the last, I found a photon over here, you're making the beam area bigger, and you're dividing power divided by the area, and the beam, your radiance value goes down, 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 down. The bigger the wider you determine the area to be. There's a reason why we want to get this 1/E squared point. It is where most of the light is, and 86.5% is the common way of doing it for lasers. We find, unfortunately, people maybe using non-technical proper instruments for doing this. They're using things like a ruler to determine the size of a beam. And so that leads to inaccurate reporting of the beam area. Why is that important? Because when you take the power and you divide it by the area, you get to the irradiance. The irradiance you're going to discover is a very important topic. I'm going to come back to it. I'm going to walk through a couple of other things, and we're going to come back to irradiance. I want to get to the fluence bit here. So pulses, the jury's mostly out. I know that people like pulsing it and using it in the brain and saying what it does for, I don't know, alpha, beta, gamma, theta, whatever range. But there's plenty of evidence for that, even with continuous beams. I haven't seen a good enough paper to my satisfaction using pulses that's showing, titrating, if you like, through different pulse regimes to see if it changes the oscillations inside the brain. I'd like to see more. So it's early days for me on the subject of pulse regimes. Treatment time in second, well, yes, you've got to apply it for the right amount of time, haven't you? And if you use it for a certain amount of time and you multiply it by the time multiplied by the power is the energy in joules. Not everybody uses that figure, but fluence is the most common representation of dose. It is the power divided by the area, wherever it is, multiplied by the time is the fluence. The one thing I do trust you to get right, and everybody gets right when I'm happy to believe you, I'm happy to believe whatever time you use. It's the one thing everybody can get right, is if you say you used it for 1 minute, I believe you. That's an easy one for you to get right. It's difficult to get other things right, like the beam area, for example. Wavelength, by the way, it's not even easy to get that right, well, particularly if you're using lasers. More and more of us are using LEDs and they're more stable. Lasers are never the wavelength they say they are. They're quite approximate. If you think you've got an 8-10 nanometer laser, it's plus or minus potentially 10 nanometers. You can, and we do, buy within a narrower range. You can get within 5 nanometers for that. But when you turn it on, let's say it was 810 nanometers when you turned it on, it warms up and the wavelength moves as it warms up. It moves about 1 nanometer per 0.4 degrees Celsius of temperature. And as things warm up and the wavelength moves with it as well. So if it goes up by 20 degrees Celsius, then you've moved it by about 8 nanometers from 810 to 818 nanometers, for example. Nothing is quite exactly, no lasers are exactly what they say they are. They're approximate. Does it matter? Do you know what? It's beginning to look like it doesn't matter. I was going to do a slide on this, and I didn't, but I can tell you there's just about every visible wavelength. There's, well, across the spectrum, blue, green, yellow, orange, red, into the near infrared, further into the near infrared. I can see Francisco's on the line here, and he's been using 1064. You kind of go up there. You're getting into what some people might technically call infrared by the time you get to that point. Depends which book you read. And in dentistry, there are dental lasers which they turn the power down, diffuse them, going quite far into the infrared, almost up to 3,000 nanometers. And they still seem to have some interesting effects with a diffused, low-powered beam at 3,000 nanometers. That's well into the infrared by there. So anyway, I think I've got more coming up to us talk about on wavelength coming up. Anyway, I want to get to this fluence topic down here. You probably, anybody who's been around photobiomodulation knows that there is a dose, hopefully an optimal dose. So if you don't put enough light in, you don't have an effect. You put a bit more light in, you begin to lose the benefits. If you put too much light in, the benefits go away. So here we're getting anti-inflammatory effects, we're having regenerative effects, and you're getting your blood flow increasing, all the things we hope and expect to get from photobiomodulation in the brain, more blood flow, more brain-derived neurotrophic factor, better metabolism, less inflammation. That's if you get this thing right. Too much, and the effect goes away. So I did some work, for those of you from Boston will know what was MGH in Charlestown. There's a pediatric thing there. I think you're there now, Paolo, as well, on that end of town. Anyway, we did some work with Michael Whelan, and we investigated, and we took these in our rat studies through to here and all the way down to here, so you could actually have make things worse by over-treating deliberately. So dose response curve, people talk about the Arndt-Schultz curve, and this is it really. So we try to stay in here when we're doing treatments. And so people have shown this in wound healing, for example. If you put too much energy in, you get this, well, you get the right amount, you have positive effects on wound healing. Too much, you lose the benefit. Way too much, and you slow things down. That's what happens. But I'm going backwards up my list of parameters, irradiance and dose rate effects. Too often, and my favorite complaint, are you allowed to have favorite complaints? Do we like complaining? I think sometimes we do. You want to rant occasionally. And I'm going to think bad things about you if you do this around me. I'll smile, but dose, the popular dose is joules per centimeter squared. It's made up of the irradiance, the power density, the intensity of the light, and it's the power, the irradiance multiplied by time. gets you the dose in the middle. And therefore, I might say, if I'm going to treat a superficial condition, then I might give it 3 joules per centimeter squared. But me, I will say, I'll do 50 milliwatts per centimeter squared, and I'll treat it for 60 seconds. Because you can get 3 joules per centimeter squared by using half a milliwatt per centimeter squared and treat for 6,000 seconds. And you might be somewhere where you are below a threshold where you have no photobiomodulation effect at all. Or going the opposite way, you could put 5,000 milliwatts per centimeter squared onto a superficial condition, treat it for 0.6 of a second. You still delivered 3 joules per centimeter squared, but you won't have had any effect. There's a speed limit to photobiology. So you cannot rush these things, delivering it in 0.6 of a second. And yet, everybody who spent time around photobiomodulation is kind of aware of this, and they think they know about irradiance or power density. And I lecture, and people get up and do a new thing on how we looked at the dose rate effects of light, you know, on a new model or something. And then one more time, everybody's informed this thing exists. And then in casual conversation, they say, oh, I gave this many joules per centimeter squared, that many joules per centimeter squared. They don't say, I gave 50 milliwatts per centimeter squared for 60 seconds. They say, oh, I just did this. But which this? Did you do this and that one? Or this and that one? Or this and that one? So joules per centimeter squared by itself is inadequate for determining whether or not something's going to work or not. And I think bad thoughts about people who just say joules per centimeter squared. Here's an example. So I mentioned the acute MI study earlier on. So they give some rats a heart attack. They clamp the coronary artery. That induces an acute MI, they unclamp it, they reperfuses the heart, but they always end up with some scar tissue as a result, and then they get a photobiomodulation treatment or no treatment or sham treatment, and those in the treatment group, you can see there's less scar tissue as a result, and they do it transcutaneously through the chest of the rat into the heart. Well, they did experiments, so this is done by Uri Oron at Tel Aviv University. And he put a power meter, actually made an incision and put it under the flap to measure how much light was reaching the heart of the rat. I say, I'm doing it over my heart. She's a little down here, and they don't have it behind their rib cage in a rat. Anyway, lift up a flap, put a power meter under, put the light through the skin of the rat so that they can measure 2.5 milliwatts per centimeter squared arriving at the heart. And they did experiments to look at the dose rate effects. So treating rats after acute MI with 2.5 milliwatts per centimeter squared for 120 seconds, that's 2 minutes. That delivers 0.3 of a joule per centimeter squared at the heart. Where then they doubled the irradiance, halved the time, got it down to 0.3, got it to 3.3 of a joule per centimeter squared. Again, so if I can stop this person from calling me, I'm trying to him. I know what I'll do if they call again. So they've doubled the irradiance, they've halved the time, there's still 0.3 of a joule per centimeter squared, and you can see the effect is getting better. They've moved from here to there now, and then increasing the irradiance by a factor of 4, reducing it by a factor of 4, you're down to 15 seconds, 20 milliwatts per centimeter squared, still 0.3 of a joule per centimeter squared, same so-called dose every time, 3 different results. So don't talk to me about joules per centimeter squared. Talk to me about milliwatts per centimeter squared and time. You can tell me the joules per centimeter squared if you like. It's not the only one. Some of you have been around long enough from outside the cave of brain research and other areas of photobiomodulation will know the name Ray Lanzafame. I know Anita will know Ray. Yes, he did a reciprocity of exposure, time and irradiance on energy density during what they call photoradiation, one of 1,000 names for photobiomodulation, on wound healing in a mouse pressure model. Okay, and yes, you can see here, I'm going to do the line for you. Non-significant, non-significant, every time keeping the joules per centimeter squared the same, got this optimal dose up here, which disappears when it gets over there. So every time the same dose, only one of them was effective. Joules per centimeter squared is too simplistic. So do we have to reach the target when we're doing photobiomodulation? I have no doubt that getting light to the target, your an anatomical target of interest, is the best way to treat for photobiomodulation. It's been demonstrated here in this study. And this is just a wound study. We're going to come to the brain soon. There's plenty of brain slides coming up. Don't worry. In this experiment here, students were being talked to by their professor, who had a piece of card, put 2 holes in it, put it on the forearm, got some sandpaper out, put sandpaper over each hole, and made these sort of grazes on the forearms of his students. They did have a topical anesthetic before they did it. They gave photobiomodulation to one wound and not the other wound. And there's a placebo group who got a placebo treatment to one wound, but not the other wound. So the black bars here represent the wound area of the photobiomodulation treated wound. And you can see that after 10 days here, the wound area is far smaller than the gray bars, which was the placebo treated wound. There's no surprise there. PBM helps you heal. And this is almost 25% of the size of that. So it's almost 4 times faster than the untreated one. But we know that, that's what we expect. The white bar was the wound that was not treated, but it was on the adjacent arm, the arm that was adjacent to, that's right, the wound that was adjacent to the untreated one. So there were 2 wounds side by side. They treated one. The white one is the untreated wound on the same limb as the treated one. You can see that is healing much faster than the control group, the sham group there. There has been an indirect systemic effect, maybe as simple as increased blood flow going down the arm as a result of the treatment. Right, so now I'm going to show you 4 papers. So this is one of Francisco's papers here. And in his paper, so he likes using 1064. It's got a 3.4 watt laser. It's 250 milliwatts per centimeter squared. And that's the bit I want you to focus on, actually, the 250 milliwatts per centimeter squared. And it had some effect on the, the psychomotive vigilance task. I think I got that right, PVT, and other benefits as well. There, it's written down there. Psychomotor vigilance task is in there. An increased number of responses in the delayed match to sample test that they do. The point is, they're using 250 milliwatts per centimeter squared for 8 minutes, and quite a high amount of energy there, 60 joules per centimeter squared. I'm using that as my sort of baseline to then show you another paper here. Oh, this is Paolo's. This is depression. This one here, using 33 milliwatts per centimeter squared, treating the dorsolateral prefrontal cortex and reducing depression in the active treatment group compared with controls. Over here, so well, that's quite a bit less, that, isn't it? And now we're getting down to 33 milliwatts per centimeter squared. I wouldn't have thought much light was getting through to the whatever the target was. And Marnie's on the call, I think. I seem to have chosen all the right papers. Everybody's here. So this one's here is 22 milliwatts per centimeter squared. This is getting to quite small numbers in photobiomodulation terms. You know, really, if we're going to get much light through people's hair, are we going to get it through the scalp? Is it going to get through the cranium? Is it going to get past the dura? Are we really going to reach any cortical neurons with this level of irradiance? You wouldn't have thought so, but her Stroop trial here seemed to get some improvement, and the Stroop trial for inhibition switching, and the California verbal learning test there, and a long delay free recall seem to have improvements as well. Whoops. Anyway, and there were other things as well Marnie was getting, which she said, yes, people had improved sleep and had fewer PTS, post-traumatic stress disorder symptoms, better ability to perform social, interpersonal, and occupational functions as a result. So clearly getting a result in that study. Now I'm getting down to 6.4 milliwatts per centimeter squared. This is incredibly low by photobiomodulation standards generally, let alone when you're trying to get light through the skin, through the hair, the skin, the scalp, the scalp, getting into the cranium and into past the dura and into the cortical neurons. So now I'm bringing you back to a few slides ago. I'm thinking, does PBM have some kind of indirect or systemic effect? And again, more California verbal learning test things here, whatever this thing is down here, Wechsler Adult Intelligence Scale. Seem to be some improvements. So this is before and after. People getting better on this scale here. Got some p-values down there. And for people like me, not a doctor or a scientist, this is a little more convincing, looking at the blood flow areas. So these are areas of low cerebral blood flow where you can see all the dark patches on here. You know this better than I do. I assume you all work in the brain. And there's baseline, and then here is after a course of 18 treatments. For a set of parameters you wouldn't have imagined would have worked. Now, this is a device that does go all the way around the head and the top, and whilst the irradiance is quite low, and the joules per centimeter squared is quite low, was used for quite a bit of time, and they did get nearly 4,000 joules of energy into these patients. So it's, and 3 watts sounds like a lot, but it's distributed over a very large area. The irradiance is quite low. So now I'm beginning to think that I don't think much light could have been getting there. Surely there is an indirect mechanism. I know it's been speculated that PBM to the scalp will get light into the blood, and the blood, there are emissary veins running through the sutures of the skull and getting into the brain that way, and maybe that's a mechanism. And I know Hanley's on the call, and the number of studies she's done on hemodynamic effects with light. It doesn't seem to take a lot in order to do it. Do we have to actually reach the target? For completeness in this study here, they did say in 8 out of 12 participants, areas of low cerebral blood flow improved. 4 participants showed no increase in regional cerebral blood flow despite positive clinical responses. And then the speculation about if more dosage, one might have done better in them. So I don't know what to think. I mean, in the lab, it's consistent, including the work that I did with Michael Whelan at, down in Charlestown at the Pediatric Center, and that these irradiances were, and I've shown you some examples, haven't I? The heart stuff, the wound healing in mice, seems to be very sensitive to dose rate effects. Dose rate effects being the irradiance. Now I'm seeing, it seems to, every irradiance seems to work. And by the way, all the wavelengths were different as well. It doesn't seem like wavelength is critical. This is a very poor performing wavelength in terms of penetration. This is 629 nanometers. It's not a great penetrating light compared with what Francisco was using at 1064, or the others were, there was some 830 something and 870 nanometer in the other one. Those are relatively good penetrating wavelengths. This is low irradiance, poor penetrating light, and yet people are having effects on this. So now I don't know what to believe about dose anymore. I don't know what to do with that information. And besides, as you know, I don't believe you anyway, or any of these people about their parameters, because they probably haven't used the right instrument anyway. And who knows, they might even just made simple mathematical errors in their papers as well. So anyway, that's why I don't believe any of you. I don't believe even what we do here in this place. I don't believe anybody, so I don't even believe myself in this field. So I've come to the end of my sort of rant why I don't believe anything. And if I was talking about mechanisms, I wouldn't believe that either. I'm satisfied with some really bland blanket statements now. PBM improves for the brain, improves blood flow, it reduces inflammation. That's like the first thing that happens. Blood flow, of course, improves cellular metabolism as well. All these brain-derived neurotrophic factor turns up, and things just seem to get better. And that's about as complicated as I'm happy to get with this subject. I'm going to give a quick shout out for there's going to be a conference on photobiomodulation in London, PBM 2024 in August 23 to 25. That's a Friday, Saturday, Sunday. London is an awesome city to come to if you haven't been there recently. It's in a great location, just the other side of the Thames River, opposite the Houses of Parliament. You can walk across the bridge, you can see the Queen Elizabeth Tower and the Big Ben thing and the Parliament. You keep going, there's Buckingham Palace, and you turn right in all these fancy royal parks, and you end up in Piccadilly, and you can go shopping in Regent Street and Oxford Street. You can turn right, and you can go into Carnaby Street, go into Soho, and it's a great nightlife area. Go off down to Covent Garden, maybe, and then go across another bridge and come back in a big long circle back to the hotel. It's a great city to walk around and find food and fun. Take the kids. There you are. that's my little brag for that. So I'm going to thank you all for coming. Thank you all for going. You may clap your hands. Right, there we go. Oh, look. There you go. Oh, more wavelengths.
Thank you so much, James. I wish we were not.
I wish you hadn't invited me.
I wish we were not muted so that we could actually hear everybody cheering and laughing. And it's been a quite a deep and entertaining presentation. So I wanted to open it to everybody else to see what questions that there are in the audience. You can decide to maintain, I guess it depends on everyone if they want to pin you still or not. But
I didn't give Fred a shout out or Marvin a shout out. Didn't put any of their research on there. But I know that Fred, you were using 250 milliwatts per centimeter squared for all your opioid use disorder papers.
If I can get started, James, thank you very much for this presentation. And I think the stage where you are is a perfect state so that we can have a clean
confused
slate.
And angry.
No, I'm not angry. I'm very happy. I'm very happy. And I suggest very quickly, one way to try to disentangle this apparently conflicting results, is to realize, like you pointed out, that there could be different mechanisms and different ways that this phenomena is manifesting. So one way to do it is, for example, decide that you are interested in a target, like what we do with for example, with the cytochrome oxidase, the photooxidation of cytochrome oxidase, and then define parameters that achieve that change in the target, and demonstrate somehow, like with simulations or other means, that you can get to the tissue that you're trying to target. And then you can find within those constraints, what are the dose responses.
But you use broadband near-infrared spectroscopy as well, don't you?
Yes. Yeah, we use this broadband near-infrared spectroscopy to actually measure how the target is modified while you're providing the treatment. So there is no guessing of what's going on in terms of what you're doing with your target. The problem becomes when you're trying to understand this across many different experiments that use very different parameters and will likely have different mechanisms operating on. Not to say that they are right or wrong, just to say that they are just different. And when people are trying to put all of this together, like what you're trying to do, well, it's not going to work. You have to have certain criteria. But I would suggest that if there are groups who've done these details, like you pointed out very appropriately, we need to know all the parameters that you spell out. I think you spell out like 10 different parameters. We need to know all of them. And then we need to know what's happening in the target that your mechanism is supposed to be targeting. And then we can have these other outcome measures that are the real ones that we are interested on. Like it could be, for example, our cognitive changes. But yes, I think this is a wonderful way to tell to the field, we need to move one step forward. It's not enough to do what they have been doing so far or what we have been doing so far. We have to tie these things together. We have to tie our parameters, our physiological effects, and our primary outcome measures, and see how they relate to each other so that we can gain confidence that what we're doing is doing these changes based on what we think we are doing with the photobiomodulation. So
Yes, I
that's
agree.
all I wanted to say. So it's wonderful that you are doing this and making this aware. It doesn't help anybody to have all of these parameters all over the place, incomplete reporting, and then nobody really knows what's happening.
Thanks.
Thank you.
Any other comments or questions or thoughts?
Well, this was certainly, James, thank you for doing this. It's so important, certainly for the people who are coming into photobiomodulation from the neurofeedback world that I've been inhabiting for a long time. You know, we have the QEEG as a way to measure brain function, and we have normative databases for those comparisons. And I think that if we were to take the QEEG and the near-infrared spectroscopy that Francisco's using and Han Li is using, that we can start to create some accurate measures of change that are normatively based and empirical in ways that, you know, aren't so easy to fudge. And that we can work backwards from the near infrared and from the QEEG and measure changes in function, both behavioral and cognitive and neurophysiological. So there are ways to pull all these pieces together, and I just think that it's going to take, you know, the next generation of people to think this through and pull the pieces together, and that's what's really important. So I appreciate you not believing anything and that you're still open to being titillated.
Yes, thanks, Marvin.
I see, I think Leon and Attila.
Yeah, sure. Yeah, great talk, James. And it's fascinating to see that skepticism is always what drives science and advancement, right? What you just exposed is really bad science. That's what we see overall in fields like photobiomodulation, like neuromodulation in the beginning.
It's a complicated science as well, I think. It fits into the banner of bad science, but it is a complicated, it is a complicated matter.
The thing is, when you present that everything, all parameters works for everything. I'm also a placebo researcher. So I know well how placebo works. I'm a neurophysiologist. So what I think is, as was expressed before, we need to have a consensus of first how a photobiomodulation paper must be. In the world of medicine, pharmacological agents, they go through a very hard pathway to get to the hands of the clinicians. And the clinicians, they don't really care about parameters. They don't really care about pharmacodynamics or pharmacokinetics because they already assume all of these pharmacological parameters were previously tested in preclinical models. I think in photobiomodulation, we also lack these preclinical models to understand well the whole idea of mitochondrial activation and so on. That's too simplistic just to see. It's way more complex than that, as you mentioned. So I think as a group, it would be good to start thinking about to set up guidelines to say, just like the world of non-invasive neuromodulation started doing it some 10 years ago. We need to be clear in this. We need to report all of this and be very clear about conflict of interest, because there are also another thing that is lacking in this field. So I think these type of talks are eye-opener for many. Great talk. Thank you.
Yeah, Leon, I like the idea of there being a group that gets together, and it's not enough to. Everybody knows now that everybody's probably joined the World Association for Photobiomodulation Therapy, knows these parameters exist, but I think we need a group that's specifically working on how do you measure these things consistently. I'm quite sure that if we sent our products to different labs, they would come back and they'd all give me a different answer. So I think we need to work on how to a way of consistently everybody actually getting the same getting the same readings, reporting this accurately, reporting their parameters. It's difficult.
I see, Marvin. I would just say that PBM 2024 could be a venue to do that.
Yes.
Marvin, go ahead.
I hope I can make it.
Cool.
I think thank you for a very nice talk, and you described all methodological problems, but I think your talk missing a major part: what to do in science so you believe in it, or maybe it make another talk about it. What is your vision on what we need to do? And maybe not only methodologically, because it's clear that we need to measure everything and everything should be appropriate, but what to do scientifically to make a clear evidence, so like in particular you will believe in it.
Right. So what you're asking, what do I think scientifically we need to do to improve the reporting of parameters? Is that your question?
And to improve scientific variables that will show the effect.
I do have some proposals, and it's particularly difficult. Laser beams, single beams, and well, they're the easy ones, and those are the ones we still don't do very well. It gets more difficult when we have clusters of LEDs or lasers, and if you have a cluster in a certain area and you have 10 LEDs in it, then there might be, say, an inch apart, but then you may have another one the same size which has 30, and they're like a much closer apart, and the density of them is much greater, and we can't do, maybe one with just 4, and it's like one in each corner. How do we measure a cluster of LEDs? Do you measure each one individually? Do you measure them as a group because the light sort of begins to diverges, the beams overlap with each other? And there's a whole other thing I have to go on about, which is when laser beams are really small and you put them on tissue and they scatter, that's fine. But then if you find another laser beam which has got, let's say one was 1 millimeter squared area, another one was 2 millimeters squared area, you test them both, you will probably find they both deliver light to the same sort of depth and have similar scattering patterns. They have the same clinical benefit, but one would produce a dose of twice that of the other, because the area, if you double the area, put the same amount of power down, the same amount of time, but doubling the area, you halve the reported dose. And if you're just reading an academic paper and you said, hey, these people use 10 joules per centimeter squared, or 20 joules per centimeter squared, and all it's changed is the 1 millimeter squared of area of a beam has changed. It's insignificant clinically, but mathematically it's a big change. And I think we need a committee that thinks about these things from a photobiomodulation perspective and begins to rule on something like any beam that's less than, I don't know, a few millimeters squared of area, about 10 millimeters squared. Anything less than that should be just considered, they should all be considered 10 millimeters squared. This is not a new concept I've invented. This is the authorities who do laser safety. They have something called MPE, maximum permissible exposure, what damage to your eye or what might do damage to your skin. And they make the smallest area that they will use is effectively 0.1 of a centimeter squared, 10 square millimeters. Committees, I'd like to have committees that would work on that specifically for photobiomodulation. So committees, how you set up your instruments, and support for reviewers, because not all reviewers are competent to actually check the dose reporting in academic papers, and you kind of need a little expert group. But where's the money for that? Expert reviewers work for nothing doing papers, and mostly you don't even get much thanks for it either. So how are you going to form a group of people to just review every photobiomodulation paper? And really, we have to get our hands on the instruments and work with people before they start their studies. I mean, when you look into it, it becomes a big topic. I'm all for it, but I need some enthusiastic people around me to participate and to actually get it done.
We have a few minutes in case there's any last questions or thoughts.
Come on, Anita, just say hello to me. Oh, and Marnie as well. Good.
Marnie.
Okay, thank you. I just wanted to mention that on the hip-skinned paper with the brain imaging, the single photon emission computed tomography, and it showed increased actually eventually after the series of the transcranial PBM treatments. It was not red light only. I just wanted to mention that. It was also near infrared. I think that was 870 or 850. I don't remember that either, but I wanted to really mention, and this is opening up, you know, a whole new can of worms here, is it was pulsed. And not only was it pulsed, to make life interesting, they had 3 different pulses.
Yeah, they did.
I mean, good grief. It was all Nogier frequencies.
All right.
And they had 73 hertz and I don't know, 146. And then they, whatever that times 2 is. And they did 3 different ones. And they did have the lowest power density, milliwatts per cm square, which you mentioned, which was what? I don't know, 6.8 or 8.6.
Yeah, that's right. Pretty small, yeah.
Yeah, it was very small. It's the smallest one, but he had some other things maybe going for him. I don't know. So I just wanted to comment on that. They did use pulses and 3 different ones.
Yes. The brain might be unique regarding pulses. With Mike, you know, Hamblin and I did a review of the effect of pulsing, and unless you went to very low frequency pulses, there didn't seem to be any difference between continuous beams and pulses, but the brain, of course, have these oscillations, and maybe there is something special about the brain and pulses that isn't true.
There is, James. There is. I mean, Lou Lim and I showed that back in 2017 at the ISNR meeting, where you could actually see the propagation of alpha from pulsing the light from the V light at 10 hertz, and you could see the propagation change because the EEG changes in response to the pulsing on the scale.
Was that compared with continuous?
That's what. Yeah. Well, no, it was pulse 10 hertz. And
yeah, no, but did you compare
the propagation change?
Yeah, did it compare 10 with continuous?
It didn't. It wasn't. Yeah, it wasn't the same.
No. Okay, it wasn't the same. Okay.
So you can get changes, and Lou's listening, so he was there.
He was there.
Thank you.
Alrighty.
Thank you again.
I think we reached the hour, and thanks a lot, James, and thank you all for coming and for this very inspiring discussion. Till the next one. Take care.
Love to see everybody.
Take care. See you in London.
Yeah, good. See you in London.